This conference will now be recorded.
So, good evening, everyone. This is not a voice you're used to hearing. It's Rick Davis, and we're sitting in for the regular team today. Phil will be leading the session. I'm just starting it off. Welcome. This is Active Surveillance. We're recording this group. It's the fourth Wednesday, the 22nd of October, all day. And this is a group for early active surveillance. If we've got anybody in the group right now who's dealing with a situation of recurrence, this is not the group for you. We're not that type of active surveillance. We just work with the gents who are still trying to figure out if they can actively survey or if they need treatment. Quick word of thanks to our sponsors who are Novartis, Johnson & Johnson, Bayer, Myriad, Foundation Medicine, and Telix and Blue Earth. I think I got everybody. With that, I will hand over to Phil to conduct the meeting.
Thank you very much, Rick. Okay, so I think we will start with Steve. Why don't you take yourself off mute and tell us a bit about yourself? I just have a few questions. Where are you living?
Yeah, so I'm in Yardley, Pennsylvania.
Okay, good. How did you hear about AnCan?
Yeah, so I started my journey a few weeks ago and talking with everyone I could and everyone who has a friend who says, hey, you should, talk to this person, and people I've never talked to before. And a friend of mine had a friend who I may have been on the call, maybe on the call tonight, I'm not even sure, that turned me on to this group and said, hey, I'm in a very similar situation as you. Maybe something that might be some value to you. And so far I've been trying to just immerse myself in as much knowledge as I can and try and learn as much as I can and talk with as many people as I can.
Okay, well, you've got a good opportunity here tonight to ask any questions that you're interested in. How old are you?
I'm 70.
Okay, so you were just diagnosed?
Yeah, I was just diagnosed about 3 weeks ago.
Okay, where are you being treated in Pennsylvania?
So I'm right now, I will be going to Fox Chase Cancer Center.
Good.
The doctor there wasn't my first doctor. It was actually a second opinion that I had, where I ended with Mark Smaldone, who's a doctor, one of the lead urologists over at Fox Chase outside of Philly.
So what can you tell us about your diagnosis?
Yeah, so I was diagnosed with Gleason 7, 3+4. After a series of biopsies. I had one biopsy that showed cancer out of the 12 that they did. And prior to that, I had an MRI done that kind of got me to that next step of biopsies. But I started with a different doctor at a Penn Med in Princeton. And he was a urologist that my wife sees. He ended up going out on medical leave, and someone who was filling in for him, who's quite a top urologist in the country, just came through the Duke University Fellowship Program, actually did the biopsy on me and highly suggested that I get surgery. It's like, active surveillance is something that you could do, but, in my estimation, I think that you should have your prostate removed. And it's like, hey, that's really interesting. Need to dwell on that for a little while. And what I'd like to do is get a second opinion, one, and I also want to talk to an oncologist, which I've done both of those as of last week. And and as well as talking with my primary physician, who's been great in terms of support and helping to help make sure I ask the right questions to the right people. And when I went for the second opinion, Dr. Smaldone had said that, hey, because you're 70, you're healthy, you have 1 out of 12 cores, your PSA is only 4 at this point, 4.1. Uh, you know, I don't really have a surgical ego at this point, was the quote that I remember distinctly.
Good
And
quote.
yeah, great quote. And he says, if you want to have surgery and you want to feel comfortable, sure, okay. I do minimally invasive type stuff and nerve sparing technology, robotic and all that. But he goes, I think you're a good candidate for active surveillance, and that would be his suggestion at this point. I then, after that consult, I talked to an oncologist over at Penn Med who had a very similar suggestion that based on what he knows about me, based on the fact that I was one core, low PSA, I'm healthy, I'm fairly fit, eat well, I'm active. He said, do the active surveillance. You have options at this point. And
Great.
that's the path that I'm leaning towards at this point, like 99.9999% there. Okay. Now, both of the doctors did say that if under active surveillance, there's the oncologist and the doctor at Temple, Fox Chase said, listen, if something changes, then, you got to make a decision, then, we'll help you make that decision, but why rush it at this point?
Good.
So that's kind of where I'm at right now. And just, again, trying to absorb everything. And one of the things that's pretty interesting is I really relied on AI to help frame the conversation as well. That it was probably, I play around with AI a little bit, but nothing like I did with this, and really kept asking the questions, going deeper, looking at studies. The studies would turn you on to other studies. And it was just basically really great about focusing information quickly, not having to go through reams of websites literally to try and distill out what those relevant facts are. And it was everything from surgical to techniques to studies that were done with respect to continence and sexual function, all that type stuff kind of got teed up in a pretty good manner with a lot of disparate sources. So it wasn't like you're just hearing it from one particular source. You were hearing it from basically all over the world, with a lot of stuff. So it was pretty enriching, and I was able to get up to speed fairly quickly, even to the point where the doctors, in the short amount of time, said, like, wow, you're asking great questions, and even things that they probably wouldn't share with me. I was kind of prompting them to share that information back with me. So it was pretty novel.
Have you had your biopsy, a second opinion on the biopsy?
Yes. Now they looked at it. I haven't had. I saw a video actually today. I watched of. I think it might have been on a different group site, but I think I learned that group through this site. Get off the top of my head what it was, but it was about the not the radiologist.
Pathologist.
Pathologist, yes, thank you. The pathologist saying that, second opinions, and he goes, there's like probably 8 or 9 people in the world that he would send it if it was him to for a second opinion. So I've not done that yet at this point. Other than Fox Chase did get all my records, and I think they were going to try and get my samples from Princeton.
Okay. So do you know what percentage of category of pattern 4 was in the biopsy?
That was a question I got from the video I watched today. I don't know that off the top of my head. The only thing I saw in the records is that it was, I think, let me pull it up here. I think it was like 10%. The carcinoma measures 1.2 millimeters in linear extent. It comprises 10% of the tissue core. So that's the only thing I have with a percentage on it at this point. But I don't believe that's the number, percentage of number 4.
Yeah. So I guess that's what. I think what you'll find, what most of the guys in the group will say is that, most of the people here who have had pattern 4 in their diagnosis have had a second opinion from, someone like Dr. Epstein or Ming.zhou, just so that they could really solidify in their mind whether it really was pattern 4. And that's obviously something that, enters into a decision. But I mean, you're one, I think the advice that your doctor has given you is like spot on. I mean, you're 1 core out of 12, good health, relatively youngish, and active surveillance, it sounds like a good idea for as long as you can do it.
Yeah, agreed. My wife also is in that camp as well. Once the initial shock of them telling you have prostate cancer and you should have surgery soon, once you kind of got past that and had a chance to digest it, kind of down to earth a little bit in my decision making and not kind of reacting to the emotion of the moment.
Exactly. Have you got any questions for the group, or anybody else have any comments that they may want to ask?
I don't have any questions at this point. I just really want to listen today and learn. But if there's something that comes up, I will certainly raise my hand.
Sure. Good.
Well, I'm guessing that Steve's next big decision point is going to be, does he get the confirmatory biopsy in a blind fashion if his MRI is negative? That's what we all had to wrestle with. So
Yeah. Again, I tripped on that today about and Dr. Epstein was the doctor that I watched the video of today.
Yeah.
So that may be someone that I reach out to for that. And I guess my one question as I think about it is coordinating that, since my original pathology was done at a different place in Princeton Penn Med, is probably working through them. And I'm not sure how I would get it to connect with like a Dr. Epstein or someone of that caliber.
Is there anyone here who's done a second opinion with either Epstein or Zhou that might want to comment on that?
Well, it's a
Go ahead.
little different. It is a little different because if you go to Epstein, if you go to Dr. Epstein, it has to go through your doctor. So you would have to call Penn Med, or you can call Dr. Epstein. We can put the information in the chat window. Eric usually does that. I'll try and do it in a second and pin it to the top. But if you go to if you want to go to Epstein, oh, thank you, Bill. There's Epstein is in there. By the way, for those of you who are new, the chat window are the two little bubbles next to the 21. Click on that and it'll open up. And Dr. Zhou, we'll get Dr. Zhou there in a minute. And Dr. Zhou, you can call your your pathologist and ask them to send straight to Dr. Zhou. But if you go through Dr. Epstein, it has to be generated in a different way. Let me say that. I'll go back to Phil's question. Has anybody done it so that they can point us out here? Who's gotten Kirk? Have you have your hand up? Have you ordered
Sorry,
a second opinion?
I raised my hand before you asked that question. I have not, but that was my question. So maybe I'll defer to Roger since he had raised his hand and he had it done.
Okay.
Yeah, someone, I can't see. Yeah, Roger. Go ahead, Roger.
Yeah, I'll give you a very similar situation, Steve. But I've been on this for about, I don't know, 5, 6, 7 years. And so I went through, and this group helped me immensely. I haven't been on for 4 or 5 months. I've been kind of enjoying, just passive, nice situation. But anyway, so I had, diagnosed 3-3 originally.
Hold on, Roger. Roger, we have you down and we'll definitely talk to you. The question on the table right now is, have you ordered and we'll come back to you, don't worry. Have you ordered an opinion from either Dr. Epstein or Dr. Zhou?
You beat me to it, my apology. Yes, I had Dr. Zhou, Ming.zhou, and he downgraded to 3-3, but I'll save that for later. But yes.
Okay, so tell us how you ordered it. How did you order that?
I literally just called him up and got on his schedule and had my slides. The toughest part is moving your slides physically from Mayo to them. I know they can do it digitally. Maybe, that was two years ago that I worked through it, but that takes a bit of work to push that through the system.
Okay, so did you call Mayo and ask them to send the slides to Dr. Zhou, or did you call Dr. Zhou?
Both. I mean, you
You did
got to
both.
work that system because your slides get lost in the process. It's not as easy as you think, but it's very doable. It's the right thing to do when you get a little hockey stick up to 3-4. That's what I did. It makes sense. And yeah, I don't need to update you any further other than I had a little PSA bump. And so
Okay,
these
so
guys are
Roger,
all in all. We're all
we don't want to jip you. We'll come back to you. We'll give you all the time. We just try to avoid people diverting the conversation to themselves when we're still working with somebody else. So
Yep.
we'll definitely come back to you. Don't worry. So
Hey, Rick,
I
think Dr. Epstein was very clear when he gave us that nice lecture that if you call, now that he's got his own company, if you call him, he will basically, take the baton and
Right.
tell you either what you need to do or he'll do it himself. But I thought that
Right.
was interesting.
No, I thought that was the case. That if you got contacted Dr. Epstein, he would at least give you good instructions as to how you could, run the gauntlet and get the thing done.
I was going to say he reread mine just a month and a half or so ago, I guess, and he has a form that he asked that the other doctor fill out, and I met with pushback at Mayo, and I contacted him, and he said I will request them, and a week later I had a result.
Good.
It was
great.
It was that easy, and I asked to talk with him personally, and he called me and gave me a short conversation.
Thanks very much, Michael. That's great. Perfect. Okay, so Steve, if you haven't got any more questions, we'll go on to our second newcomer and pop in when you need to.
Thank you.
So can I just ask the question, because I think it might be relevant to Steve as well?
Sure. Go ahead, Steve.
Because I got a confirmatory biopsy today, and I am considering getting a second opinion. And I know this group strongly recommends Dr. Epstein and Dr. Zhou. I'm just wondering from the experience, is one preferred over the other, or how do people decide, like between Epstein and Zhou?
No, both excellent. You will not be disappointed with either.
Right. So let me give you, let us frame it for you, and then you can decide. So Dr. Epstein, for many years, for 40 years, ran the lab at Johns Hopkins. And you will hear a lot of people on the boards and with experience saying, oh yeah, I'm sending my slides to Johns Hopkins. Well, the reason they sent them to Johns Hopkins was because Dr. Epstein was there. Exactly. And there wasn't an opinion that went out that he didn't look at. He looked at everything that went out. So if somebody else did the work, it came under his nose before he sent it out. Now, one of his top students was Dr. Zhou. And so Dr. Zhou worked with him for a long time. And then Zhou left and went to Tufts, I think it was, in Boston. Dr. Epstein left Hopkins for a couple of years, took a sabbatical. And so the people that were left at Hopkins had all been trained by Epstein, as had Dr. Zhou, but it wasn't Dr. Epstein. Dr. Zhou basically adopted the same approach as Dr. Epstein, and he would talk to all the patients, and he was very engaging, and he had a very, very good eye. And for a while there, you couldn't get to Dr. Epstein anyway. So we started sending stuff to Dr. Zhou. Now you have a choice. Zhou's moved to Mount Sinai in New York, and Epstein's started his own practice in New York. So you can go to one or the other, but one's the teacher and the other's the student, but they're both very good.
What about price?
That was very helpful, but yeah, I'd like to hear the price too, if we can talk about it.
Well, the price, the last we heard, Epstein was around 450. Michael may know because he just got something done. And Zhou was a little less expensive, was around 250 or 275.
As far as I know, Medicare covered my second opinion. I haven't
Okay.
gotten a bill for it. And I
Okay.
was led to believe that in many cases they did cover a second opinion, but now everybody else's insurance is different.
Yeah.
Yeah.
But I think what the price you quoted, Rick, was about correct. Epstein
Okay.
used to be a touch less, but I guess now that he's in sole practice, he needs to make a living. So maybe he's a bit more.
Hey, Phil, that was my question I had, so I don't need any more time. That answered it.
Okay, thanks, Kurt. Okay, so our second newcomer is Mark. Mark, you want to go ahead? I spoke with Mark today. Mark is a fellow Canadian, so.
Yeah, so I'm also in Toronto or next door. Anyway, yeah, so I'm kind of similar to Steve, I guess, but many years earlier. So I was diagnosed in 2018. Same thing, 3+4. But Steve, one thing you should check too, although you get 12 needles, there's usually 5 cores per needle. So there's actually 60 samples they take. So I was positive in 1 core, which means 1 out of 60, not 1 out of 12. So, and it was about, well, I've heard two. One time they said 10% 4, 20% 4. Anyway, long story short, this was all when I had a Gleason 5 when I first went in. Had a biopsy, no MRI, had a follow-up MRI. They found a lesion, which was PIRADS 3, but the lesion wasn't in the same spot as the 3+4 that was found earlier. So this place was pushing the HIFU, the ablation. So they said, well, and they were trying at the time, they were trying to find perfect patients to get OHIP approved. They were doing a study. So I could have gotten the study, but the lesion didn't match. So they said, well, we can still do it for like $20,000 and, you know, blast half your prostate. That didn't sound very good to me. So they did a second biopsy of the lesion and my whole prostate, including where they found the cancer the first time, this time doing 18 needles and an MRI guided, and all 76 cores, you know, 18 times 5, if my math is right, or 80 cores, I guess, came back negative. So they couldn't even find what they found the first time. But my PSA was still rising. So I did another MRI in 2022. PIRADS was 3, did another one this year. And now they said the lesion was showing PIRADS 5. But there was an issue when I did the MRI, so I wasn't really trustful of it. So I went to Banff Health in Grand Rapids. A buddy of mine knows somebody. Anyway, I went there, got a second, you know, a second MRI or a new MRI, and they came back PIRADS 2. And then they requested all my information. Even the doctor said, well, that he didn't believe it. It was too good to be true. And then they got all my results, prior results from Princess Margaret in Toronto, sent that to the radiologist at Banff Health, which is part of the University of Michigan. And then he changed his opinion from a 2 to a 5, which I was like shocked. So now I'm very jaded on the whole, you know, how they're measuring. And so then my PSA had gone up to 17.6, but now recently it's gone down to 11. So now I'm kind of like, hey, I'm just going to wait for a bit to see what's going on. But now thanks, I spoke to Phil and found this group, you know, I'll try to get second opinion and be more forceful on, because I'm just dubious now of, it just seems that you ask, 10 people their opinion, you get 10 different answers. And this is serious, obviously, right? So.
Mark, could I ask a question? When they found the lesion on MRI and you had subsequent biopsies, did they do fusion biopsies? In other words, they fused the image so they knew exactly where they were biopsying. They fused the sonographic image or the MRI image with the biopsy machine.
They told me when I went in for that second biopsy, which is the last biopsy I had, he changed when he said it was only PIRADS 3. He said, okay, I'm going to do a It was MRI guided. I don't know if it was fusion, but I know he had on one screen. So I don't think they were fused. I think he had the prostate on one screen and then the MRI on another. I'm not sure, to be honest. I mean, obviously it was prostate on the bed and he was jabbing that thing at me. So it was a rectal one. So it was MRI guided, but still, I don't know if it was fusion.
Rick,
But definitely he poked the lesion.
I was just wondering, Rick, whether Mark would benefit from prostate ID.
I definitely think he might. I'm not certain about how accessible prostate ID is to a Canadian resident. That might be an issue. Have you looked into that, Phil, or not?
I have not. I was hoping. Well, I guess the best person to speak to would be Bing.
Yeah, Bing. We can help you, but I kind of feel that we have to get more clarity for him, because that a prostate ID isn't going to give him the clarity that he needs, and that's the problem. Let's throw it open to the guys and see what other people think. I have a couple of ideas, but I'd like to defer to the wisdom of the group, where we have a situation that is all over the shop, from PIRADS 2 to PIRADS 5.
Yeah.
Gleason, we haven't asked Mark. Has the Gleason ever been? Have you ever had the slides reread, and have you ever had second opinions on your Gleason grades?
No,
I have not. I didn't realize that was an option, so I have not.
But I've sent Mark information for both Epstein and Zhou, so that may be something that he'll do. But I mean, he's only had one core, which is 3+4 with, as he says, a maximum of 10 or 20% 4. So the issue is sort of like that rising PSA, which obviously is somewhat of a concern. But I mean, it's bounced around, and it sort of sounds like more BPH than.
Yeah, the strange thing, though, to be fair, is my prostate is tiny. It's like 29 cc's. Wow. So it's like, that's why if there were more cells, it was growing, you could explain that, but it's not. So
Mark, that actually kind of works against you in this situation, because that means your prostate density, your PSA density is way higher than. Who's guiding your care? Is it a urologist, or who's the captain of the ship right now?
It's an oncologist at Princess Margaret, which is part of
an oncologist. And what are they advising you to do?
Well, he's Mr. Haifu, the ablation, and I always joke with my friends, is like, when somebody only has a hammer, like everything looks like a nail, right? So yeah. That's all he suggests.
If they can't find the damn thing, what are they going to ablate?
Well, that's what he said. He would do a hemi ablation, and I mean, like hemisphere, like half. He said yes. I said, well.
So that means you have a 50-50 chance of getting the cancer if it's in one.
Well, no, presumably the cancer is in one section of the
cancer. The lesion. Yeah, the lesion. The core that was 3+4 and the lesion are in the same hemisphere.
Yeah. Okay.
Still, it seems.
I think there's a couple of things here. I mean, first of all, we'll tell you that we're not big fans of focal. And the reason we're not big fans of focal is because the failure rate is very high. Overall, the failure rate for focal is about 50%. But if you consider that they treat a lot of people with 3+3 who don't need treating, most of the people who fail focal are probably 3+4. So we don't know. I can't tell you the focal failure rate for 3+4, but it's probably a lot higher than that 50%.
Sorry, Rick, how do you define failure? A recurrence or?
Yes,
a recurrence that you need second treatment. I mean, we're dealing with somebody right now in the high risk recurrent group who had IRE, electroperculation 10 years ago, and and it's back, and he's trying to figure out what to do. He's working with University of Michigan to figure out what to do. But we're not big fans. For some people, yes, it works, but a lot of people are attracted to focal because they see it as the magic bullet, and it really isn't. Now, you had
And
one
I could, sorry, Rick, and I could also offer that this was back in 2019, and it still hasn't been approved by OHIP. So that tells me something's not good, right, Phil?
Well, it's not so much that it's not so much that it's not good. It's just that OHIP says, why do something like that when there's all other proven treatments? So, you know, they're reluctant to have like 40,000 treatments. They want to keep it nice and simple.
Now,
Well, and I think what they were talking about at the meeting in LA was that, you know, focal is great for someone who's maybe really old or really has a lot of medical problems, and you want to kind of do the least amount of invasive work possible. And, but, you know, for someone that's in good shape and maybe has a longer life expectancy, you know, as Phil said, there's probably treatments that have that are more definitive.
So I would even step back one before discussing treatment. And most likely the doctor that you're seeing at Princess Margaret is a urologist or a urological oncologist, because those are the people who generally do focal. Occasionally it can be a radiation oncologist. It's usually a urological oncologist. I doubt that you're seeing a medical oncologist. So when we say oncologist, we have to distinguish which type of oncologist. Now,
I'm sorry, can I ask a question?
No, you can in a second. We see your hand up. We'll come to you. Okay, just be assured that we'll come to you. Now, the question that I'm asking, if it were me, is haven't had a biopsy since 2019. My PSA is jumping all over the shop, and sometimes it's pretty high. Don't know for sure if it is related to inflammation and BPH. Could be a bunch of things. We don't know. We haven't talked about that. I would be looking, before I did any treatment, I'd be looking to get a biopsy again. In fact, one of the things that we've recommended to this fellow who had IRE 10 years ago and is looking to do more treatment is you need another biopsy. If for no other reason that we want to know that 3+4 that he had 10 years ago, you had 6 or 7 years ago, is it still a 3+4? Because if it's now a 4+5 or a 4+4, your treatment options are going to be different. So we've got to drill down on those treatment options. We got a guy who was 3+3, 3+4 when he first had focal treatment. And when he came back in again, to get more treatment 2 years ago, he was a 4+5. He was a Gleason 9. So we've got to be looking at that. Jim, what's your comment on this subject?
I was wondering, talking a little bit about this idea of getting new biopsies and then rolling back to this idea of focal therapy. I think some of us have talked about, some of the people we see online talking, and Dr. Schultz is one of them. And he's very, very much against biopsies. He thinks that they're unnecessary and potentially dangerous for puncturing the capsule. And then the idea of, I know this group has not been a huge fan of focal therapy, but if you had only had your cancer on one hemisphere and you took the focal on that, if 5 or 10 years it comes back and you need to do something, well, isn't that better than doing something now between the 5 and 10 years? If let's say you're going to have the radical prostatectomy, man, if it gave you 5 to 10 extra years of full function, wouldn't that be better?
Well, there's a couple of things here. First of all, I have never heard, and I may be wrong, but I've never heard Schultz oppose biopsies. I think he opposes too many biopsies and biopsies too frequently, but I would not characterize Mark Schultz as opposing biopsies.
Agreed.
In fact, we've known people that he's wanted to biopsy. One problem with Schultz is he doesn't do transperineals in his office. So if he's going to give you a biopsy in his office, he's going to give you a transrectal. We moved a guy, he's not in the group tonight, but he's been in here frequently. We moved a guy from Schultz to UCLA just to get a transperineal biopsy, which is really what we're pushing. Now, to answer your question about isn't it better? We don't know when the disease is going to come back. If you've got a 4 in your number, a 3 plus 4, we don't know where that 4's gone. We saw it in one place, but it could have moved all around the prostate. That's the whole problem. We don't actually see the 4. Just because it doesn't show up on a MRI doesn't mean that it's in different places. And that's why it recurs. So yeah, you can roll the dice if you want. You may get 2 years out of it. You may get 10 years out of it. But it isn't, in our view, if it's serious enough to require treatment, if it's moved beyond the point where it's not comfortable to do active surveillance on a 3 plus 4, then it's not suitable for focal treatment. If you're a 3 plus 3, should you get focal treatment? Well, we'd say no.
Yeah.
Based on what Dr. Clark says, based on what Dr. Carroll says, 3 plus 3s are safe to do active surveillance on.
Yeah.
So if you're getting focal treatment with a 3 plus 3, you don't need it. So that's how we'd answer that question. Dr. Dan, you have your hand up.
Yeah.
Yeah, thanks. So Rick, I totally agree with you. My discussions with Dr. Scholes, he's not against biopsy. He's against multiple blind biopsies.
Yeah.
So he says that's just like, it's like target practice with a blindfold on. So the other question about, isn't it better to do something, minor and gain 10 years? Well, the approach that what he would say, or what the literature says is, prostate cancer in your prostate is 100% treatable. Prostate cancer that's escaped the prostate and metastasized is very difficult to treat. So the whole game is picking the right time to nail this thing while it's still in your prostate and not letting it get loose. So maybe it's better to have a good 10 years, but not at the expense, not if the horse has gotten out of the barn. The other thing I was going to say to Mark is that I totally agree with what Rick is saying. First of all, Mark, you can't use BPH as an excuse for with a prostate volume of 29 cc's. You can't use BPH as an excuse for
Oh, no, I realize.
Yeah.
Yeah.
So it's either prostatitis, some kind of inflammation, or it's cancer, but cancer doesn't go down either like that. I mean, although even if it's gone down from 17 to 11, your PSA density is still pretty high. So
Yeah.
The one thing that I haven't heard much discussion about in the group is not only is the old transrectal biopsies not that safe, or it's not safe, period, but there's also parts or there's regions of the prostate gland that are not easily accessible with a transrectal biopsy. There's parts of the prostate that can be sampled with a transperineal biopsy, and that is even, I think, a better reason. If they're having trouble figuring out your situation, it might be useful to try get a transperineal biopsy. As much as having people stick needles in your prostate is not fun, but your case is just one question mark after another, and you definitely need some clarity. I totally agree with what Rick's saying. You can't, and what Phil's saying, you can't talk about treatment. You got to diagnose first, treat second.
Yeah. Steve, you had your hand up?
Yeah, it just, one of the questions I have, it kind of just popped up, is in terms of the frequency and, frequency between biopsies. I mean, in my case, I was recommended that probably in 9 months have another biopsy to confirm. And just with what I heard the group say earlier, guidance of getting another read by the pathologist, is that sufficient, or is another set of biopsies recommended just to confirm and make sure they didn't undershoot or overshoot for that matter?
Well, I mean, typically you would have a confirmatory, but I mean, you know, the gold standard has been to have a confirmatory biopsy within 12 to 18 months. You know, you'd probably be better off having an MRI and then having a confirmatory biopsy, because that way you'll just be able to confirm that the MRI is the same as your initial MRI, and then they can do a confirmatory biopsy, whether, you know, they see anything on the MRI or not, and then they'll do a systematic biopsy. But, you know, that I think is what sort of the process has been.
Okay, that cleared up the question. Thank you.
So Phil, this is exactly what the art, it's not an argument. This is what the debate that Dr. Schultz is involved in. If you're under the care of a urologist, Steve, he's going to want to do the second confirmatory biopsy because that's how they were all trained. And the medical oncologists are saying, look, these blind biopsies, it's like shooting in the dark. And he believes strongly, after 10 years of doing it this way, that he can get just as good or even better result by following you with PSA and MRI. If something shows up on the MRI, then they do a focused, targeted biopsy. And that's really one of the big areas of debate right now. And all of us at some time or other are going to be caught in the middle of this discussion or this debate, which is pretty uncomfortable because, you know, you got one doctor on one side, he's got a white coat on and he's saying, do this. And the other guy's got a white coat on and he's saying, no, do this. And you're in the middle trying to figure out what the hell. And, you know, and it's not a totally objective decision since, as I said, nobody loves having a bunch of needles stuck in your prostate. So it's a difficult place to be.
Rick?
Thanks, Dan.
Rick,
Yeah, I think that this is an excellent discussion, and I'd really like to pull in a few of the other guys. Jim, we'll come to you after I've done, because there are several guys in this group who have really done a lot of work on confirmatory biopsies and how long to wait. Traditionally, it's been 12 to 18 months, just as Phil said. But now, in situations where you are pretty stable, a lot of the urologists are willing to go out 3 years. I should say those are usually urologists in centers of excellence. One of the things we know, sadly, is that the biopsy is a huge moneymaker for urologists in community practices. And, you know, we try not to be cynical, but it is a factor, and you have to take it into account. And they'll sell you a biopsy because they can, and because it makes them a lot of money. But if you go and talk to a doc who's in a center of excellence, like your guy at Fox Chase, or the guy we like particularly at Fox Chase is Dr. Correa, who's terrific, they'll say, no, we'll just push it out. Let's push it out. Let's see how far we can go. Now, that's not true for everybody. I mean, if you're there right on the edge and, you know, you've got 2 cores or 3 cores of 3+4, and you've got 30 or 40% 3+4, 4 in those cores, maybe that's a different situation. So we've got to factor this in as to how much you have. But what, you know, 1 core of 3+4, of which, you know, the whole core is there's only 10% cancer, and we don't know what percentage of that 10% is for, but it's certainly not more than 10% of the total. So we're talking about millimeters here. You know, maybe you can push it out. But let's go to Jim. Why don't you come?
Jim Kirk, and then Mark.
Yeah, and I'm sorry. I'm trying to. I really respect you guys so much. I want to understand the logic of the focal, because it seems to me I think I'm missing something. And the idea is, if you have 3-3, well, we all agree. I think you don't do a thing. And when you hear these people losing their, you know, side effects because of a 3-3, it's difficult. But when we're 3-4 and you start to say, okay, once again, you're getting pushed to do something for the whole gland, pushed to do something for the whole gland. So doing a hemispheric, some sort of focal, especially if your cancer is all on one side, and then you go on the same exact, in my mind, it would be the same exact active surveillance. So the idea of don't get the temporary thing done because eventually you might have to do something later on if it, and you don't want it to get out. Well, we don't want it to get out if we do nothing. We don't want it to
Okay,
get out.
so let me, got your point. Let me respond.
If you know where I'm going, then go ahead.
Yeah, no, I've got your point. Let me respond. We know statistically that focal therapy is successful about 50% of the time. We also know that a lot of focal therapy is done on 3+3s. So that 50% includes 3+3s and 3+4s. And sadly, because we've seen it, we've seen people with 4+3s getting it. Should never have gotten it. It's not recommended by the AUA, but they do it because they can. And because men are willing to roll the dice. So we know that there's a lot of people that overall it's 50%, but a lot of those 3+4s, it's probably up around 70, between 70 and 80%. And they have it on one side and they're a good candidate, but it isn't successful. And quite often, pretty quickly, they come in for a second treatment. And we see these guys because they come back to our group, not this group, and we have to advise them. Now, the problem is that you're sitting there thinking, well, my cancer's all on one side and I can't see it anywhere else. But in fact, there's a concept of what we call micrometastasis. And that is usually applied outside the gland, but it's just as relevant and pertinent inside the gland. So the cancer can change, but it isn't big enough for us to see it. And in fact, the whole concept of cancer not being great enough to see is now becoming prevalent in considering active surveillance. Just because you can't see it on an MRI doesn't mean there isn't cancer. And so what we're saying is if you've got a 4 in your number, it could well be that those little bits of 4 are all around your prostate, but we just cannot see it. So why are we taking a chance on treating half the prostate when really we should be treating all the prostate? And you're rolling the dice on what we can't see. Because we can't see it doesn't mean it isn't there. Does that help, Jim?
Yeah, I guess. But if you don't know it's not there, the same thing would be true if you did nothing. So it wouldn't.
It wouldn't. It's not true. If we don't know it's not there, but we can't, we can't rule out you don't have it. You may have it. Then if you decide to do a treatment that treats half your gland and you want to roll the dice on the other half of the gland, 75% of the time you're going to lose.
Well, but if I do nothing, I'm going to lose as well.
Well, if you do nothing, the cancer could get out the gland altogether, just like Dr. Dan said, and then you're in trouble. Look, I was a 4. I never could do active surveillance. I was a 4+4. They suspected that the disease was outside the gland. At the time we did a color Doppler because that was the state of the art technology. We didn't have PSMA, etc. back in the day. And I also looked at my nomogram, and my nomogram on my MSKCC said that there was only a 30% chance that surgery would be successful. It was probably outside the gland. Based on that, I said, this is what I'm going to do. I'm not even going to do surgery. Never mind not do focal. I'm not even going to do surgery. I'm going to jump right in and I'm going to treat it all. Did I overtreat? Maybe I did. But 17 years, is it 17 years? 17 years later, my disease hasn't come back. And I was a 4+4, T3B, T3A. So yes, if you want to roll the dice and you want to do surgery, you want to do focal, be my guest, but don't come crying when the disease comes back. And the longer you leave it, the more likely it is to get a foothold. Kirk, what's on your mind?
Yeah, I was just gonna follow up on your talk about confirmatory biopsies because I literally just had one 4 hours ago, and I was on this meeting maybe 2 or 3 weeks ago asking for advice about whether I should get a confirmatory biopsy. The recommendation from this group was probably not because I'm Gleason 3+3 as diagnosed a year ago. I did talk to my urologist, and he strongly recommended I get it. And the reason why I did get it is because for my situation, I'm considering getting HOLA. And he said that it's probably best to get confirmation about your Gleason 3+3 score before you get the HOLA, because if you, it's much harder to, your treatment options are limited after you get the HOLA if you actually do have prostate cancer. So for that reason, I'm 3+3, diagnosed a year ago. I went ahead, got the confirmatory biopsy. I'm hoping it comes back, stays the same. I will get a second opinion from either Dr. Epstein or Dr. Zhou. Hopefully, if that confirms 3+3, then I'll go ahead and get my HOLA. So that's why I got the confirmatory biopsy.
Okay.
Mark?
Kirk, is there anything on your MRI?
No, the MRI was 3 weeks ago. It was completely clean. So
So it
Mark?
was a blind confirmatory biopsy.
it was, yeah, random samples.
Mark?
Yeah, no, I just because I'm new to the group, I was just wondering because I'm living under this the yoke of the PSA, right? And every time when it was 5, I thought I was dying. When it was 9, I thought I was dying. And so are for people on active surveillance that have been for a long time, is anybody like at 30 PSA? Like what's like PSA is just PSA, right? It's not. It's potentially a marker, but it's not necessarily. You can have deadly cancer with a low PSA. So, there's no safe level, but is anybody, like, I'm just curious as a group, like, hey, I've had 20 PSA over 20 for 15 years. I'm still active surveillance, or what's the sort of status quo? Or like, I know Phil's been a long time, but he's down at 5. So he's kind of like, well, not the same boat as me. Although I've been pretty stable at 9, 10 for like 4 years, and except for the 17.6, which I thought was a UTI. And now it's come back down. So I'm saying, well, maybe a PSA of 10 is normal for me. I'm almost 70. I've been aging. It's been growing, since 2011. It's gone. So what's anybody living
Jeff?
with a high PSA in the group here?
Jeff, you got a comment?
Yeah, my comment is, Mark, in reference to your concern about your PSA level. This isn't personal to me, but Phil and Rick, Thrain, right, from Iceland?
Yeah.
Thrain, that for ASPE. Anyway, we were on a webinar one time with him, and he was on active surveillance for 14 years. And he showed a graph that he had created for every PSA test he had taken over the course of 14 years. I'm trying to find it, but I can't. I have it down here somewhere. But the bottom line is his PSA level over that 14 years bounced up and down to the point where sometimes it was as high as in the 20s, in the 30s. And then it looked like a sawtooth, just like this. It would go up and down. It looked like a stock market. You know what I'm saying? So I'm simply saying, even though it's not personal to me, there's an individual that is known to this group well enough, and that was his situation, at least with PSA levels over the course of 14 years. So I'm just throwing that out there.
All right.
Thanks,
So
Jeff. Bill Wood.
the situation with PSA is very, very tricky. PSA is an indicator. It's a flag. I can point to you people who have had PSAs well under 4 and have had very serious cancer.
Yeah.
4+4, 4+5, 5+4, because they don't necessarily make PSA. At the same time, I can point to you people who have relatively safe cancer that they could survey, but they make a lot of PSA. Now, most of us are in the middle, but some of us are not. So we don't really know. All we know from our PSA is that if it's if it's low, then we have the possibility of a false negative, and we've seen it. And I shudder when these guys come in and they're newly diagnosed and they're 4+4s and 4+5s and they have a PSA of 2 or 3, because I know those guys are going to have an awful time. I would rather see a guy with a 4+4 or a 4+5 who comes in with a PSA of 15 than I would with a PSA of 2.
Yeah.
Because it shouts a variant type of prostate cancer. We just lost a guy last week, a dear guy, Mark Valens, God rest his soul, who never made PSA. And we could never get to the bottom of how to treat his prostate cancer. We couldn't see small cell. We couldn't see this morphed cancer, but he had an untreatable form of prostate cancer. So if you've got a high PSA, it is a flag, but it doesn't mean you have cancer. What it would tell me if I was Mark is I got to get in. I've got to investigate this further. The question is, and we really have to, I know there's a couple more people who want to speak. We can come back to this conversation later because we've got to get to the guys who asked for time. But
I just want let Bill Woods make a comment, and then we'll
the
go
question is, where does Mark get that second opinion? I think if it was me and I was in Toronto, I'd probably go to Sunnybrook, and I'd get a second opinion, either from Klotz or one of Klotz's guys. Yes, we know Klotz likes focal. We don't necessarily agree with him on that. He's told us he likes focal. He's got an interest in a company that makes focal equipment, but I don't think he's necessarily going to push focal, especially if it's inappropriate. And that's what I think I would do if it were me. But guys,
Rick,
Rick,
you said something that I think is really valuable a few minutes ago. I think Mark should be asking his physicians why they don't want to do a PSMA scan.
No,
I did.
No.
You can't.
Absolutely. I don't want to go down that rabbit hole, Dan, but no, he's not even close to a PSMA scan, in my view.
Yeah,
but if it was positive, he would have.
Dan, we've got to leave it right now. We can come back to it. I'm willing to stay on. I'm willing to debate it. But for me, a PSMA scan opens up too many things and it's not appropriate in my view. I certainly wouldn't be asking it. But
Bill,
can we get to the question to the people who need
Bill,
time?
A comment from Bill, and then we'll go to the 2 updates.
My PSA was 14.5 a month ago, and I'm being followed at Sunnybrook, Dr. Vesprini, and I'm in an active surveillance group associated with Dr. Klotz. And my PSA density is quite high. My prostate is only 35 cc. 2.5 years ago, I was diagnosed with grade group 2, 3+4 with less than 5% pattern form of the cribiform. And I'm being followed with PSA, and I'll be getting more MRIs and/or a micro ultrasound with Dr. Klotz is required.
You know, Mark, I'll get you connected with Bill when you send an email, okay? Because it'd be a good idea for you to speak to him.
We're in the same boat, it sounds like. So
exactly, and you're both in Canada, so you know Bill's in Oakville, so it's a heck of a lot easier to understand the medical.
Okay, Phil, thank you.
Okay, so Roger, update.
Yeah, I'll be really brief. The most important point from the earlier conversation, I believe, for Mark and Steve, is that Ming.zhou and Epstein are both uropathologists, okay? So when I was diagnosed down at Mayo, I had my biopsies read by a renal pathologist. Nothing wrong with them, but I'm convinced that you really, if you get that 4 mixed into your numbers, that you got to get the second opinion. Either one of those guys is great. It's cheap. And it does take a little bit of work to make it happen, but it's both an art and a science. And Ming.zhou said to me at the end of it, and my wife was sitting next to me, you know, not sure about all this stuff. And he said, you know what? Don't get too many biopsies. I've already had 3. And so the point that a couple of guys made earlier is just don't get too many of them unless you absolutely positively have to. But, you know, MRIs and PSA as a flag, as was mentioned earlier. And so that's what I'm doing. And my stuff, I just had a little higher PSA bump up. And so I got to, you know, it doesn't freak me out. It just makes me go back and probably do an MRI and see another PSA. And, you know, lastly, if I had to, I would go back to a biopsy. But that's all I got.
Thanks, Roger.
Thanks to the group, by the way. It's been a fabulous, you know, 5+ continuing years. It's really great stuff. So
Keep coming back.
Yeah.
You know, I think we'll go to Ray, because Ray's got to leave, and I think you're perfect timing.
Okay. So after the webinar on precision prostate consulting, I had both my MRIs read by them. And let me just give a brief history of myself, because then you can draw your own conclusions as to what their report said. So March of 2024, my PSA had gone from 2.1 to 3.9. Might have really been 3.6, but it was 3.9 at the highest. My urologist recommended I get an MRI. My MRI showed a PIRAD3 lesion in the mid-anterior transitional zone. That was the only lesion it showed. In June, I did a transrectal biopsy, 18 cores, 6 of which were at the lesion. 5 of the 6 were 3 plus 4, with 3 to the 4 being 3 to 5%. Subsequently, I had a Decipher test. My Decipher was 0.26. I had a color genetics test. I had no genetic mutations for prostate cancer. I had 2 more PSA tests that came in around the 3.6 range that year. And when I was diagnosed, I was told I needed to lose weight. So I started losing weight. I was told to eat a plant-based diet. So I started eating more plant-based. For the new year, 2025, I decided to go full vegan, cut out alcohol, and kind of take a food as medicine approach. Any food that may have been shown to be cancer suppressing, I was eating on a daily basis. Anything that may have been tumor promoting, I was not eating at all. Late February of 2025, my PSA went down to 2.3. In June, it was a 2.5, at which point I had another MRI. And the MRI showed the same lesion on the mid-anterior zone. It was a little smaller. The radiologist called it basically unchanged and had it as a PIRAD3 again. So I submitted all this information to Precision Prostate Consulting, and it turned out the report on the 2024 MRI, they showed 2 lesions. They showed my midline anterior lesion, and they also showed one in the peripheral zone. Both of them were what they have a scale to, I think it's 0 to 100, and both of them were in the 60s, which would equate to a PIRAD4. They then looked at my MRI in 2025, and they showed no lesions whatsoever. Even though my 2025, they identified the lesion, the radiologist did. So my question to them, and they were very nice. They said, you know, look, we're going to look at it. We're going to have our people look at it. We're going to do it. And they came back and said to me, they stand by it, that their service is to identify 3+4 or above. And if something were to fall below that threshold, it was not going to identify it. And they said they stood by their 2025, that there was nothing showing that would have been a 3.4 or above. So that's my story, and that's what they came up with.
Congratulations.
So I mean, I hope they're right.
Yeah. That's interesting.
So any questions or?
You
How
know,
did you how did you get them to read, or what was the process?
I just, well, I don't, if the webinar is still up, I mean, I just went to their website. I filled out the forms and, you paid the money and I was able to download my MRIs to them.
Okay.
Rick?
It
yeah.
was,
So I'll put the link in for the webinar momentarily. It's really tricky because their AI is based on closer to 7,000 records. And really what they're doing is that they're looking at your MRI, they're comparing that to all the knowledge that they have, and they're trying to determine from what they see if that correlates with what they know, because those 6,000 or 7,000 records come from what they know. So is it definitive? No. It sort of reminds me, I don't know how many of you know what a nomogram is, but back in the day, nomograms were kind of similar to what AI is. In fact, nomograms really are is early AI. They take your record, they compare it to everybody else's, and they predict what your results are going to be based on on all the similar results. So, is it true for you? It's not true, but this is what we think. So Ray's sitting there, and yeah, we saw something a while ago. We don't see it now. Ray's done. He's taken some significant quality of life steps, and we've seen people before who take these quality of life steps, and they get great results, and we don't necessarily see the cancer. Does it mean the cancer's gone? Just like I said before, because we don't see it doesn't mean it's gone, but maybe all of those little cancer cells aren't aggregating in one spot. So, what is it? I think we need about 10,000 of those cells. No, it's more than that. I can't remember the number anymore, but we need a significant number of those cells aggregating all in the same place to show up. And if they're not aggregating there, then they're not showing up, then we can't see them. So are they saying his cancer is gone? No. Are they saying he needs to do something right now? No, he doesn't. So, so this should give Ray the peace of mind. I don't know how we give Ray peace of mind. That's a very difficult task, but this should give Ray enough peace of mind that he can keep going for a little while longer. He's okay on the active surveillance, and that's where we are. I mean, that's how I interpret it, right?
Yeah, my big question is the confirmatory biopsy, which I've been resisting do. I didn't have a good experience with my first biopsy. Yeah. So I've been trying to, unless there's really a compelling reason to do the confirmatory, which I'm trying to push that out. And the AUA guidelines just they went to 12 to 24 months on the confirmatory. Right. So if things don't change, I'd like to push it out to 20 to 24 at least and see what's going on.
I think for people like you, most of you gents here, as long as you're actively surveilling and you're watching your PSA and you're doing your MRIs and you're looking after yourself for quality of life, your cancer's not going to get away from you. And that's the best anybody can say. I just want to mention for the new guys, I put the germline study, the Promise germline study. The Canadians, I'm sorry, it's not available to you. The Americans, it is available to you. This is a free color test, but you have to move quickly to get it because they're pushing their limit. And I will right now. Give me a second, and I'll put in the link for the for Prostate ID for the test that Ray just went through. We got
Greg?
Mr. Burns.
Yeah.
Hi. Hey, listen, guys, I don't know exactly where to stand on this. I've been with you for 2.5 years. Many of you know my story up and down. I'll give it to Cliff Notes. 2.5 years ago, diagnosed with 3 + 3, 6. Then about a year later, it became 3 + 4, a little bit of 4, less than 5%. And then a year later, a little bit more for up to 10%, but mostly 5% or less. I started to get a little freaked out, to be very honest. And I know this group is not about freaking out and controlling our freaking outness, but I'm first to admit I was freaking out because I had an MRI in January of this year. And unbeknownst to me, it said something to the effect of possible escape from the prostate, and which registered honestly with me in June of this year. Just after I had my third biopsy, which came back again with some 3 + 4. So that at that time I thought, well, wait a minute, what should I do? And people said, get a PET scan, get a second opinion on your MRI. Getting both of those was a pain in the you know what. I was able to push for I eventually got my doctor was saying they don't do second opinions on MRIs, which I eventually got to NIH. NIH came back and kind of and did give a second opinion and said more or less confirmed that what the first one said is, it's close to the edge of the prostate. And again, every direction said get a PET scan, get a PSMA scan, which again I had to push for, and eventually. I think after NIH confirmed with my doctor as a second opinion that there's some concern, for whatever reason, I was able to get a PET scan, which I did last week. And I'm very happy to say that it came out, I believe, negative. I mean, it's from what I can understand, it's a PET CT. It doesn't say PSMA, but it says PET CT. And it said, nothing in the lymph nodes, nothing. But from what I understand, getting, oh, by the way, my decipher is 0.21. So anyway, but having said all that, my urologist now is saying, it might be time to transition to treatment. So I know that right now, Rick's going to cut me off because we don't do treatment here. We don't talk treatment. So I don't want to talk treatment, but I'm at this transition, maybe with some of you have or will, at some, this transition point where when do you decide if the cancer is, I guess it's in the prostate, right? It's for me, my cancer is in the peripheral zones, which I understand is, the edge of the prostate. So at what point do you say, okay, I don't want this to escape. I think I've, will dodged a bullet so far. My PET scan is saying it's not outside the prostate as far as they can tell. So, at when do we make decision? When's the call of, prudence versus, kick the can down the road or 6 months, year, or what? So just any opinions, if Rick will allow opinions on that.
Oh yeah, no,
yeah.
This is a very valid conversation. We're not talking about treatment options. We're talking about, do we need treatment or not? Right. And this is a very valid conversation. What do people have to say about when you have to take the plunge? Everybody's had so much to say tonight, but now when we come to the real, where the rubber meets the road, everyone's quiet. What's going on?
Bill, go ahead.
I'm 84. I've been on active surveillance for 15 years, and I guess 2.5 years ago, when I was diagnosed with grade group 2, 3 + 4 with 5%, less than 5% pattern form of the cribriform, I was told that regardless of what I would do, it would make no difference in my longevity. So I made it to 84, and I guess if things go the wrong way, I know there's treatment available. My father died of prostate cancer in '93. I had a germline test that was negative for that. It's not hereditary. So I feel that I'm lucky I got to 84. And just take it the way it comes. So not a big problem. And I know what my treatment possibilities will be, and I'm comfortable with them, but I will probably never need treatment at 84.
Just to confirm, my PSA started around 5. It's gone up to it was 7.1 a month ago or a few weeks ago. So that's the highest it's been. It's been bouncing around between 5 and 6, and then now it's spiked to 7.1. But anyway, that's just neither here nor there.
Well, look,
Well, you're
Greg is. I was just going to. I was just going to say, Michael, Greg is not 84, so we can't cast him into that. But Michael, what's your thought on when you have to jump?
Well, it's $1 million question. It's just like we've just said here, who's somebody who's discussed he's 84. I'd be very hesitant to jump into any whole gland therapy at the age of 84. But Greg, we've listened to you and travel around the world, and you're obviously a very young, healthy guy.
68. 68. Yeah.
But you're a youthful 68. And I say so much of it's a very difficult decision, but I also think of quality of life as being a huge question in there, and what I value. But if I were in your position and we're dealing with just what you just got through saying, I would be so struggling, and I am in another position where mine is a struggle, but it's because of other issues, not what's been seen on the MRI so far. It's just got to be a weighted, value-based decision, and I don't think anybody. I think there are times when you can say, okay, you've got 60% of Gleason 4, you're a 4+3. Now it's time to treat. That's it. It's a done deal. But so much of it's not an absolute slam dunk. But I over and over, I think of quality of life. Quality of life now, quality of life if I do treat, and deciding how to treat, based upon quality of life afterwards and what you value, where your values are. But there's no one answer. I don't want to go too far Southern Baptist on you, but look to your greater power, whatever that is, and ask that question.
Greg, I don't think you should have to make this decision by yourself. I don't know who is it. You have a urologist guiding your care right now.
Yeah.
If I were you, I mean, Rick, maybe we can give him some of the names of some of there were some really good medical prostate oncologists at the meeting in LA. And I would, just spend a little extra time and a few extra bucks and meet with them, lay it all out, and let them tell you based on their years in the business what they think. My understanding is PSA under 10, is one of the better markers for, being not in a position where you've got to make a decision tomorrow. And I think you should get a non-surgical opinion from somebody, and at least that way you shouldn't have to. This shouldn't all be resting on your shoulders. That's a lot. And by the way, I guess Ray is off the line, but I think his story is fantastic for all of us. Anybody diagnosed with and who's in active surveillance who doesn't see this as a huge opportunity to make serious lifestyle changes is really missing the boat. Plus, if the prostate gland cancer doesn't get you, it's going to be cardiovascular disease. So you might as well eat the right food and do the right exercise, because that's your best shot right there.
Yeah.
I'm fortunate that I have, not fortunate, I have, I have an appointment this week with a radiologist at Stanford, and then I have an appointment on Monday with Rick's doctor. So I will get some opinion over the next 5 days.
I mean, Greg, your concern is that the cancer will metastasize.
Yeah.
So, I mean, that's why they call it anxious surveillance.
Right.
I hope that these guys will, give you good counsel. But I mean, the longer you can push it out, the better you are. Quality of I agree with the comments on quality of life. And I mean, treatment, no matter how good the treatment is, you're just not going to be as good after the treatment as you were before. Hopefully, if someone was treated, they'll come out okay. I mean, they won't have the really negative effects. But I mean, you're just not going to be the same after as you were before. I think that's just a fact of life. So, but I really feel for you, because I know, like, I've been on active surveillance for a whole long time. And when I was first diagnosed, I mean, that was the first question I had. Like, how do you know it's not spread? Like, how do you know it's, and I'm going back a long time. So I don't think the state of the art was quite as good then as it is now. But I mean, the docs that I spoke to said, well, if you're so concerned, do something about it. So I did. I stayed on active surveillance because I didn't think that was a good answer. But again, if you're really on active surveillance, like if you're really active on active surveillance, they'll catch it in enough time that you'll be treatable. That's sort of my conclusion on active surveillance. I think, Rick, would you agree?
Well, would I agree? Greg's situation is really tough, because we know that the cancer is butting up right against the edge of the gland. And that's what makes it a little bit different to most people sitting with 3+4. And that's what gives the anxiety. The 3+4 doesn't give the anxiety. What gives it is the position of where this cancer is. Now, thank God, it looks like if it was a PSMA PET, which we suspect it was, and it was appropriate in the case of Greg to do a PSMA, because the cancer was pushing right up against the gland, and we wanted to make sure it hadn't gone through the edge of the capsule. So if we have that comfort, then Greg's okay to date. But you're playing with fire at this point. When we've been watching it for this long, how much longer can it be before it gets through and it starts getting into the edge of the gland? And we're not going to do, in Greg's situation, it's probably almost certainly not going to be surgery. It'll be radiation. How big a margin around the edge of the gland do we have to take? We don't really want to be shooting at the lymph nodes if we don't have to. I actually, I think that the problem with seeing Mac is he's going to say we need to treat it. I mean, I can tell you, because that's Mac. And he won't say, no, we're not going to do anything. He's going to say we have to treat it. The person that I would see, and I think is better than a medical oncologist, would be Peter Carroll. Because Peter Carroll has got so much experience in terms of treating these types of situations, has seen so much, and he's not a urologist who says treat. He's a urologist who will push active surveillance as far as you can possibly put it. So notwithstanding what Mac would say, I would say, one of the most experienced eyes that you can get anywhere in the world and close to you. It's like going to see Larry Klotz in Sunnybrook, we said before. I would love to know whether Peter says, I wouldn't mess around with this much longer. Yeah, you're doing the right thing. You're seeing Mac, let Mac treat it. Or if he thinks you can get away with it longer, he'll tell you. And that would be my best advice right now, to see Mac, because he can put together the right treatment program for you. But on whether or not to stay on active surveillance, I would trust Peter's opinion.
Okay.
Do you know, Rick, does Dr. Carroll do virtual appointments too? Or I know Cooperberg does.
Yes, if Matt does it, then
Yeah, Mac does.
Well,
Dr. Carroll's office offered me a virtual appointment. I'm going in person November 12th, but they offered me virtual too.
Okay.
Good.
And you know, I've known Peter since 2008 when I sat on committee with him, and I have the utmost of respect for him. I mean, God, if I had to pick God forbid I needed a radical prostatectomy, he'd be right there amongst the people that I was considering, and he is so pro active surveillance. He's not going to treat you if you don't need treating, and he doesn't have. It's not like he doesn't have a horse in the race here because you're never going to get surgery anyway. But I really feel, I mean, along the lines of what Dr. Dan was saying, but I think you're better off with a Peter Carroll than you are with, say, Rahul Agarwal or somebody else that we might recommend you to as a medical oncologist. Mac's going to say treat it because that's Mac. I can tell you. He's never going to say to you to leave it alone. But that's Mac, you know.
What you've said tonight to me, just my opinion, because you've been doing this for a while and you got multiple MRIs and you got a long history there. Sounds like, and I'm not a person who loves virtual appointments, but that sounds like a great virtual appointment type situation to get a second or third or fourth opinion on. Not if I were, needing a firsthand doctor, but to see what they say. And I've listened to Dr. Carroll's talks on YouTube, not as many as some people. I've listened to Cooperberg's. They're very, very pro active surveillance. I mean, the only person I think I've heard that would sound more pro is Stacy Loeb. Is that? I believe that's her name, Dr. Loeb.
Yeah.
No.
You're right. I mean, we're sending you the Stacy Loebs, the Scott Egners, the Matt Cooperbergs, the Peter Carrolls, and you got to remember that everything that Matt knows, he learned from Peter.
Yeah,
I can tell you that. Right? He'll tell you it came from other people. Everything Cooperberg knows came from Peter. So,
will it upset Mac if I go to Carroll?
I would see Mac anyway because I would rely on Mac for something definitive on what the treatment plan should be, and if you and the option of doing it with him. Now, if you go to Peter, you could say, Mac, I'm coming to see you because I want to know what the best radiation treatment plan is for me, but I'm going to see Dr. Carroll because I want to know if he thinks I can continue active surveillance. And Mac's going to say, well, I don't think you can. And you're going to say, well, I know, Dr. Roach, but I would love to hear Dr. Carroll's opinion. And he'll go, okay, that's sort of the way the conversation's going to go, I suspect. Because Peter won't kiss you off for going in and asking him, can I push the envelope any further? And what I don't want to see you push the envelope further if you can't. And I can't think of a better person than Peter Carroll to tell you whether you're at the edge of the envelope or not right now.
Okay. Well, and the other option is Dr. B. Boyansky with the MRI LINAC out of Stanford.
But this is why I would say that's what you got to unpack with Mac. That's why you got to see Mac. And you got to say to him, what about the LINAC? I can do the LINAC at Stanford. And let him sell you on why he thinks he can do a better job with SBRT than rolling you into the MRI tube. That's what Mac's going to, that's where you're really getting the best of the best when you speak to Mac,
Okay.
in my view.
All right. Thank you, gents.
You bet.
Did you
Okay,
get, did you get your money's worth, Mr. Burns?
As always, thank you. Yeah.
It's 9:30, guys.
Yes. Listen, I'm happy to stay on. Dan Gifford had his hand up before and he took it down. Mr. Gifford, what did you want to say on all of this? Because you always have very good views.
Well, I was going to say to Greg and kind of echo a little bit of what Michael said, but quality of life has two aspects to it. And quality of life on the physical is, everybody understands that. But I think where you're struggling is your quality of life from your mental standpoint. And everything that we've given you thus far is more information, more information, more information. I honestly think you have enough information and you're just struggling with a decision. And that's, someone said it, it's a very, very personal decision that you have to make. And I don't think anyone here can give you enough information to be comfortable with that. And I think that's where you're struggling. So that quality of life, where are you going to get the best quality of life from a mental health standpoint? Where are you going to be most comfortably from a mental standpoint? If that is staying on active surveillance, despite the advice of doctors, Rick or others, if that's where you are personally the most comfortable, then do that for a little bit longer. If you're not, then you really should go and seek treatment. And it sounds like, from my perspective, you're struggling with staying on active surveillance a little bit longer. And if that's the case, you've been given some really good information on where to go and who to talk to. So just to summarize, mental health is as important, if not more so, from a quality of life standpoint than anything else. So that's all I have.
Thank you.
Thanks, Dan.
Great point.
I know that a couple of people had some questions for Steve about Steve's case. And Steve, by the way, I don't know, have you signed up for our reminders? Have you signed up with AnCan for our reminders?
I believe I have.
Okay, so if you have, that's fine. If you got a reminder for this meeting, then you definitely have signed up. So we just want to make sure you're on the list. I'm happy to revisit. I know that Dr. Dan was saying, well, you know, I was sort of bordering on PSMA discussions. I personally, I'm not a doc. I can't give advice. I would say that unless it is an exceptional situation, PSMA scans really aren't appropriate at the level of active surveillance, with exceptions. And Greg Burns is the perfect exception because the location of that lesion of his is very, very close to the edge of the gland. And we want to be sure, because it's so close, that it hasn't gone through the gland. And that, to me, is exactly where a PSMA should be used. By and large, to use a PSMA scan for a 3+4, it just doesn't make sense. And one of the reasons is that you have to have fairly aggressive cancer for it to make PSMA. Even if you make PSMA, and remember, 20% of all gents don't make PSMA. So they go in and they get a clean PSMA scan. Their doctors forget to tell them, well, 20% of guys don't make PSMA anyway. So, you know, we don't know, and we don't have a commercial test right now for PSMA. They have a bench test, which they're using in clinical trials, and hopefully at some point soon we'll have it as a commercial test. But we don't have a test to know if you're one of those 20% of men who doesn't produce anyway. But even if you do produce, you've got to have fairly aggressive cancer to start producing PSMA. So if you produce PSMA and you're a 3+3 and you're going to produce PSMA, we won't even see it at a 3+3, and we may not see it at a 3+4. So by and large, it doesn't, the PSMA sounds good. It is a very, very valuable tool for the right purpose. I personally would not be looking to use it in 95% of the cases for active surveillance, Dan. That's my view on it.
No, I'm not recommending it. I'm not recommending it for active surveillance, but Mark's case was really unusual. Prostate cancers PSAs don't go from 17 to 9. And he's had a couple of biopsies. He's had a couple of MRI scans where they told me he had a PIRADS 5, then he had a PIRADS 3. I mean, the poor guy is walking around under the sword of Damocles thinking, okay, I got the heat.
Right.
I mean, I don't know what the hell the guy has. If he had a PSA scan that lit up in his prostate, then you tell him, look, you got cancer. But if it was negative, I agree. If it's negative, it doesn't solve anything because 20% of them don't. But, you know, what is this poor guy going to do? Is he going to keep getting more biopsies and more MRI scans? They can't even decide how to read his scans.
Yeah, look, first of all, we don't even know if a PSMA scan will light up because his cancer may not be aggressive enough to even show.
No, I get that. But if it lights up, he's got cancer. And if it doesn't, then he's still in a, I still think.
Not necessarily if it lights up. I mean, I suppose, yeah. I mean, does a prostate cell make PSMA if it isn't prostate cancer? Here's the problem. Prostate cells are what make PSMA, not prostate cancer cells. It's the prostate cell that makes it, right? Now, we're shooting at his prostate, which is full of prostate cells. So now we see PSMA. Is that cancer or is that just the prostate cells? Now, the boffins would argue, well, it's only the crazy cells that have got out of line that are making the PSMA, not the healthy cells. But we're starting to tweak a little bit when we use PSMA to look inside the gland. I don't think it's tremendously reliable. Where it's truly reliable is if we see PSMA outside the gland.
Yeah, no, I get that. I understand that.
And it's not in the esophagus or it's not in areas of your gut. There are other areas of your gut that make PSMA that can be confused. So we have to be really, really careful. I feel like for somebody like Mark, who hasn't had a confirmatory biopsy in 6 years, that's probably the starting point. Based on, you know, whatever we can see in the MRI, whatever they can do with that MRI, or with a micro ultrasound, that's the starting point for him. That's where the problem, to me, that's how to address the problem with a confirmatory biopsy since 2019, first time since 2019. That for what it's worth, for what it's worth. But like I say, you're the doc. I'm not the doc here. Anybody else want to discuss anything else on anything we've had, or is it soup yet? Can I go eat? Look, yeah, look at Michael there. He's relaxed. He's on his bed. He's got his dressing gown on. I mean, that's where I'd like to be.
How about one last little thing? I've got I'm going up to Roseville tomorrow Friday for Kaiser, and they were going to do a micro ultrasound, and the guy that does the focal therapy says, I don't think you're a good candidate. I think you're a little too beyond and spread out. But while you're up there, why don't we just turn that micro ultrasound into another targeted biopsy while you're up there and you're cleaned out and stuff? Any downside of doing that?
When was the last time you had one?
April. That's kind of close.
I wouldn't. I
No.
wouldn't let them do the micro ultrasound and see
Yeah.
what they see. If
Yeah,
they see
2 and 6
something that
months.
they really feel needs addressing, then they can talk to you about it. So, who's the doc you're seeing at Roseville? I had half of my treatment at Roseville.
Lee,
So,
Dr. Lee.
don't know. I don't know.
I think it's Joe Lee. So
Well,
the
Joe
idea
Lee.
would be, yeah.
Oh, well, it may be if he's doing their micro ultrasounds. My urologist was Joe Lee, but he's out of Terra Linda. But it might be.
Oh, you know what? There are 2 Lees. Maybe I got the wrong one because I know that I asked for a referral to the guy in Marin County, but this guy is maybe I've got him mixed up.
Okay, so if we've talked before, and if you're going to see Joe Lee in Terra Linda, you can send him my very best wishes. And
Yeah,
as
I'm sorry,
told you before, I'm
Joe Lee
only
is
here because of Joe.
Yeah, Joe Lee is the one that you encouraged me to make a meeting with, and I've asked for a referral for him. I don't have it yet from my standard urologist.
Okay.
It's a different Lee in Roseville. I forget his name.
Okay. Well, I saw Smith was the guy that I saw, who was the nuclear medicine guy at the back in the day, and he did my seeds. So
you had mentioned that, so that it was the seed stuff that you have done, and you've been back on active surveillance since. And
no.
Once you're
I
treated,
had seeds from Kaiser, and I had IMRT from Mac Roach, and I had 28 months of hormone therapy. I've never really been in a situation where that I would call active surveillance. I suppose it is, because yes, I've been watching ever since, but it's not like a recurrent active surveillance situation. I had a lot of treatment. To go back to your question, would you get a transperineal biopsy at the same time? Well, my view is only if they see something exceptional, and then they should discuss it with you. What does Phil say? What do you say, Phil?
same thing. Twice in 6 months is like not a pleasant thing. So I agree. If there was something that was really, really suspicious, then sure, they might want to poke. Otherwise, wow.
I was talking with the guy, Dr. Guillaume, that does the focal therapy, about doing some focal therapy. And he said, well, I think that you're 3.4, you're a little much. You've got a 0.62 decipher. I don't think you should even do active surveillance. You should do something. And I think that Dr. Carroll is going to agree with me. He told me yesterday, but we'll find out. But he said, while you're up there and you're doing the ultrasound, we might as well do another biopsy. So I'm assuming it wouldn't be perineal. I'm assuming it would be through the rectum, because that's where they're going to put the ultrasound. Yeah.
Well, not if it's a micro ultrasound.
Okay. All right. I didn't realize that. Okay.
Well, I don't want to say that. If it's a micro ultrasound, they put the probe through the rectum, but they don't penetrate the prostate through the rectum.
No, they'll do a transperineal. I mean, Klotz does micro ultrasound, does a TP biopsy through micro ultrasound.
Yeah, but with the micro ultrasound, where do they put the probe?
Oh no, the probe goes through the rectum. I mean,
that's right. So that's what I'm
saying.
Do it yes, they'll put the probe through the rectum, Jim, but they won't penetrate the ultrasound, the gland through the rectum.
Yeah.
Okay, because my first biopsy with them was through the rectum, and yeah, the biopsies are lousy. If it's not going to be advantageous, I'd prefer not to do it. But this guy made it sound like he wouldn't consider doing anything with me until we did another biopsy. But that could happen in the future too, especially if I don't plan on doing anything, immediately.
See what Peter says. And, you know, again, if he thinks you can push the envelope, same advice I gave to Greg Burns.
Yes, exactly. I'm in the same exact
Right.
exact spot. Yeah.
Except your lesion isn't close to the edge, is it?
Well, I sent a message today trying to figure out how close to the edge. They didn't say it was like in danger of proceeding. So I'm trying to figure out how much room there is in there and exactly. I don't understand the geography of it quite yet.
Okay. Okay. All right.
But I should have that information because I did have a PET scan. I'm getting this micro ultrasound. And then I'm not sure if it'd be applicable for Greg, but one of the doctors at UCSF is doing a carbon-13, I think it is, imaging that they're doing a trial for that I'm going to be doing in January, which is just more visibility, but it sounds interesting.
Okay. All right. Can we go home now?
Good night.
Thanks all.
Good night, everybody. Phil Segal, great job. On the record, before we switch it off, great job. You did great. Who needs Hugh? Who needs Gary? Who needs Eric? Right? Good night, everybody.
Take care.
Good night.
Thanks, Rick.
Pleasure. Thank you. Good night.